Welcome to The Verdict. Kent Myers is sitting in today, once again, I think for the last week, without Mick Cornett. He promised me faithfully he'll be back next week, but we'll just labor on in his absence and wish him the best. And by the way, he once again sends his regards to you. Sorry he's not here. But we have a wonderful show for you today, a very informative, timely show on medicine from a physician at the OU Medical Center, OU Medicine Organization. Dr. Rachel Franklin is going to be here talking to us about pain management, addiction, opioid abuse, and the like, and how one can avoid that. She is a specialist in this area. She comes really highly recommended with a wonderful background, both while she's been at the OU Medicine organization and before she got there. She's an Oklahoma native, pleased to see, and she will be talking to you about dealing with chronic pain and how to avoid prescription abuse and prescription overdose. We'll be talking to Rachel Franklin. I'll be right back in just a couple of minutes.
I like the idea of improvisation and starting with not a preconceived idea. All of my work is about visual images taken from my memory. I'm Brenda Kingery. I am an artist and I'm a proud Chickasaw. One time I said, "Oh God, please don't let me die with my paintings in the closet." And what I would want them to be is everywhere. I would want them to be loved, to be used, to be respected. You work your whole life doing this. You just keep going as long as you can. And I have such a good background with a 106-year-old grandmother that I've always thought in my mind I would just paint till I'm 106. My Chickasaw heritage has become a primary part of my life. And the reason is, it's a place I call home.
See more stories about the Chickasaw people at profilesofenation.com.
And welcome back. Kent Myers welcoming you back to our show with Dr. Rachel Franklin. I'm introducing her now for your edification. She joins us from the OU Medicine organization at the Health Sciences Center. Dr. Franklin did her undergraduate work at Oklahoma Baptist University, did her medical work at the University of Oklahoma Medical School. She is a medical director for the OU Physicians Family Medical Clinic. She is a board certified family practice physician. She specializes in dealing with families, dealing with medical problems that affect families. And of course, nowadays we hear an awful lot about opioid addiction and overprescription and overuse of such prescription medications. And she's going to talk to us today about her efforts to see what can be done to control that and to make things better. As a part of that, she's going to talk to us about what we will call non-terminal chronic pain. You're hurting all the time. You're probably not going to die from it, but nevertheless you're hurting, and what can you do about it and not at the same time become addicted to something. Dr. Franklin, welcome. Sure glad to have you.
It's great to be here, Kent. Thanks for having me.
Well, you have a wonderful background. Your family, as I understand it, goes back to statehood.
We do.
You don't, but your family does.
No, my great-grandmother told stories about bringing her grandmother's rose bush in the covered wagon to Shawnee, Oklahoma. We homesteaded between Shawnee and Meeker. And
in the land run.
In the land run.
Yeah.
Although my family separated for a while and
Yeah.
came back, I was born in Nashville, and I've been in Shawnee since I was 4 years old, and moved to Oklahoma City to go to medical school.
Well, and did well there. I know I didn't mention, and I should have, that you are not only a board certified family practitioner, family medicine doctor, but you're also a professor at the
Yes.
medical school.
I am.
And what courses do you teach at the med school?
So when I became a professor, I was teaching the third-year clerkship in family medicine as the course director for every medical student's required 4 weeks spent out in the community with practicing physicians, learning about what a family medicine doctor does. I've since moved on to direct the care provided to 50,000 Oklahomans a year in our family medicine center clinics, but I still get to teach a course from time to time, which is kind of nice.
I should say you get exposed to the upcoming and new doctors.
Absolutely.
Well, what brought you from private practice in Oklahoma City or Edmond area to OU medicine?
Ultimately, it was a passion for teaching. I was enjoying my life. I had a wonderful practice with wonderful patients, many of whom followed me to OU, and I've been eternally grateful for their continued love and support. But ultimately, I was offered the opportunity to affect the care of more than just my patients. It came down to math. I can do a certain amount of good for a certain amount of people over the course of a long career as a family doc, and I think that's a good thing. But I was given the chance to make one learner do one thing differently that impacts their patients. And if only one learner did something differently that they could attribute to something I taught them, then I helped immeasurably more people. It just came down to the fact that I could do more good as a teacher.
Do you still see patients?
I do. 4 half days a week, or 40% of my time is still spent seeing my own patients. And about 40% of my time is spent supervising our learners as they see our patients.
And that leaves 20%.
20% of time for administrative work, for running the clinic, for doing research, that sort of thing.
Of those 3 allocations, I'm sure the administrative work would be the least interesting for you, or at least perhaps, but as between the teaching and the seeing of patients, do you have a preference?
You know, surprisingly, I have become a huge fan of the administrative work as it serves the educational mission.
Well, isn't that fortunate?
Yes. You know, when I became medical director, I was responsible for the care provided to the patients. And what I learned over the course of taking classes at the OU College of Engineering, where I took my Lean Six Sigma certification, for example. You may know Dr. Poulat down there at the College of Engineering. I learned that the processes that we use to care for patients in the clinic inform the education of our learners. And so I have thrown myself into that administrative work because it creates an environment where we can ensure the safety of our patients and the excellent care for our patients.
Well, it certainly improves the quality of medicine practiced, I suspect.
We certainly hope so.
Yeah. Talk to us a little bit about chronic pain.
So chronic pain is defined simply as pain that's present for more than 6 weeks. It's a quite simple definition.
Continuous or off and on for 6 weeks?
It's continuous. It can wax and wane, but someone suffers from a pain that lasts longer than 6 weeks. We divide it into different types. You know, someone may have heard of neuropathy, for example. It's the burning, stinging, sensation-related pains of a diabetic or someone who's been through chemotherapy, for example, or what we call functional pain, people who suffer from migraine headaches or from fibromyalgia, those kinds of things, where the brain perceives impulses that shouldn't be painful as painful. So the definition's quite simple. The challenge is how to treat it. And that's where we've come down with a long history of poor care that led to guidelines that unfortunately have helped to create an epidemic that we're now trying to reverse course on.
Well, talk about the guidelines a little more specifically so
Sure.
our viewers will know what you're talking about.
Absolutely. So when I trained in the mid to late 1990s, we were taught that chronic pain was just something someone needed to suffer through.
Yeah.
You'd take an aspirin, you'd take some anti-inflammatories, maybe go do some yoga, but the doctor really didn't have much to offer. By the time I had finished my training, medical science and the experts in government and other organizations had said, doctors are grossly undertreating patients' pain. This is not okay. By the late 90s, the Institute of Medicine, the Veterans Administration, and the Joint Commission, which accredits hospitals, said that pain should be the 5th vital sign. You know, you've heard of your blood pressure, your pulse, your temperature. Those are vital signs that we take. These organizations began to tell doctors that pain needed to be something we assessed at every single visit. That's a wonderful way for us to become more aware of the fact that people suffer and we need to try to help them. The downside of it was that it created a measurement that doctors now felt compelled to manage. If your blood pressure is elevated, I'm going to treat it. If your pain score is elevated, I feel obligated to treat it. The challenge was that in about 2000, give or take, we had doctors that were being sued for malpractice for undertreatment. They were losing their licenses.
For undertreatment?
For undertreatment of pain.
Okay.
And primary care doctors like myself, who had not had specific training in chronic pain management, became quite frightened. And into that void came a drug company that said, we have the miracle agent. That miracle agent was named OxyContin, and this drug company spent a lot of resources specifically targeting primary care physicians with free trips, free meals. We are somewhat implicit in this problem as well, and told us that their research showed that this medication was so potent and so successful at controlling pain with very little risk of addiction or dependence. They gave our patients free coupons for starting the medication.
And this was in what time period?
This was from 1996 to 2000.
Okay, excuse me. Go
No
ahead.
problem. Right about the same time that we were feeling quite stressed about our undertreatment of pain, we were told we had the magic solution. Add to that mix that direct-to-consumer marketing is possible, and that as Americans, we oftentimes think that the fix to a problem is a pill rather than some self-management techniques that we could do for ourselves. And doctors who are overworked and have to care for 4 or 5 diagnoses in the course of a 15-minute office visit.
Yeah.
And you get this perfect storm where patients became the primary victims, the medical system and physicians became the secondary victims. And by 2006, 2007, the federal government began investigating. Ultimately, this drug company was convicted of a felony, and they had to give back $600 million in fines to the federal government. 3 of their executives were also convicted and paid almost $35 million in fines for false marketing to physicians.
Primarily in the area of non-addiction?
Primarily in the area of non-addiction. There were 2 lies that they told us. The first lie was that that medicine would last for 12 hours. It doesn't. So patients would say, I'm hurting again, it's only been 8. Doctors have heard it works for 12. We were creating this pattern, this cycle of up and down, euphoria followed by withdrawal for this medicine.
Let me interrupt you, and we'll come
No
back
problem.
to that right after the break, but we've got to take a quick break. We're visiting with Dr. Rachel Franklin, dealing with chronic pain, prescription drug abuse, and addiction. We'll be right back.
The good life comes naturally to Tulsa, where nature's beauty is matched with an eye for aesthetics. A legacy of neighborhoods graced with lawns and landscaping and handsome homes. A place that seems to have patented an ideal lifestyle. Bank First is loyal to the quality of life Tulsa assures its citizens, to the priority placed on education, culture, and growth. Loyal to builders who transform raw land into residential charm. Developers who see opportunity and add vitality to Tulsa's economy. Bank First serves both enterprise and private lives that need a loyal partner. It's how we help nurture this city's very good life. Bank First. Loyal to Oklahoma. Loyal to you.
Welcome back to The Verdict, Kent Myers, and we're visiting with Dr. Rachel Franklin from the OU Health Sciences Center, OU Medicine, family practitioner, head of that department there. And we're talking about the story of how we got to a crisis in opioid abuse and addiction. Doctor, when we took our break, we had just fined the drug company.
Yes.
So where did we go from there?
So 2007, those fines are paid. 2009, there is a tipping point. The CDC reports now that more people are dying from accidental prescription drug overdoses than are dying in car accidents. In 2009, it became the leading cause of accidental death in the United States, and it has not stopped since.
Wow.
So
That's 7 years.
At 7 years. In the meantime, I've been out into private practice for 7 years. And I come back to the same program that trained me. And I mentioned, take an aspirin, do some yoga. And I came back to a program whose practices mirrored those out in the community. We were giving medicines and we didn't know why. We were following what we thought were the right guidelines, and our patients were going through the same thing that patients in private practices were experiencing as well. So in 2012, we began a process locally of trying to figure out how to reset the pendulum. Our concern is that, particularly in rural communities where there's not access to chronic pain management specialists, that those patients who truly suffer chronic pain, and 100 million Americans every year suffer chronic pain, it's a big problem. We're concerned that those people without access are going to encounter primary care physicians that are now afraid to prescribe, are afraid to manage the chronic pain, and that they will suffer needlessly because we threw the pendulum all the way back instead of trying to rebalance it. So we reviewed what literature exists, and the problem with chronic pain is there's not a cure.
Yeah.
And
by definition?
By definition, there is not a cure. By definition, it won't kill you. As you mentioned, this is not cancer-related pain. We're not addressing patients who are on hospice care.
Yeah.
We're addressing patients who are trying to function in life and who are still struggling. The evidence is poor and has remained poor, and we now have some CDC guidelines from this year, but in the interim we had to figure out what to do. What we decided to do was what doctors should do in every circumstance, which is to objectively assess a patient. Ask them what's going on. We've gotten rid of the pain score in favor of what we call a functional pain score. Let's stop talking about a number and start talking about how the pain affects your life. Can you sit, stand, squat? How is your intimate relationship with your partner? How is your sleep? How's your social life as it relates to your pain? We can follow that over time. Let's assess the patient's risks objectively. First, what kind of pain is it? And is it an appropriate pain for non-pharmacologic therapy? Massage, yoga, acupuncture, what works, what doesn't? If there are medicines that are available that aren't these powerful narcotics, have you tried them? Have we optimized those medicines? And have we helped you self-manage through things like stress reduction, better diet, exercise? Once we start talking about these narcotics, let's talk about a trial of the narcotics. The medicines can work in appropriately selected patients, but the doses have been much too high, and the prescription of these medicines have not been as objectively done as we'd like to see happen. So we're trying to back up, and instead of being reflexive, saying no more for anyone, we're trying to say, does this fit a possible appropriate opiate prescription category? And if so, how do we safely prescribe that opiate?
How does a patient that goes through some procedure or has some need for pain alleviation and is prescribed an opiate, how do you transition from that opiate to some non-opiate that will give you relief that perhaps for pain that is persisting?
That's one of the most important things that has happened in the national guidelines as well as the local guidelines. An awful lot of work has been done from the governor's office through the Oklahoma State Board of Medical Licensure and others who have tried to help us understand acute pain management. You break your leg, you go to the emergency room. In the old days, in this interim when we were overprescribing, you might get a 30-day supply for a strong narcotic. What you really need is a 3 to 5 day supply of that strong narcotic and a follow-up with your primary care doctor to see how you're doing, see how we can wean you to something more safe. We are working to change the management of acute pain so that we don't hopefully develop as many people dependent on the medicine long term.
What are the options for treating acute pain that do not fall in the dangerous category?
Right. So for acute pain, for patients who can tolerate them, there are side effects to everything. Some of the best medicines actually are the anti-inflammatories. Tylenol is not an anti-inflammatory, but is also appropriate. And for some patients that need it, we can use anti-epilepsy drugs that help with nerve-related pain. Sometimes we can use antidepressants that help with achy type pain. There are times when opiates are appropriate, and we should be using those for people after surgeries, after broken limbs, after other major problems, but we should reserve their use for people who are experiencing severe pain related to that.
Well, you've mentioned a couple of things that I'd like for you to comment on. You've mentioned acupuncture, you've mentioned yoga and massage. Can you talk about those and what role those activities play?
Absolutely. For your viewers who are interested, there's a website that the National Institutes of Health maintains called NIH NCAM. I can give you that information for your website. But they have actually studied in a scientific way complementary and alternative treatments for things like pain. We know that for musculoskeletal pains, maintaining your flexibility and your strength is very important. Yoga, weightlifting plays a role in that. Stress reduction clearly helps you to cope better with pain. Acupuncture and dry needling, which is something a physical therapist can do, can help with the trigger points that are present in people with fibromyalgia and other conditions. And certain types of massage help with musculoskeletal types of pain as well.
The fibromyalgia patient, are they pretty much limited to something like acupuncture, or are there other things that can help?
It's a great question. The functional pain syndromes, like fibromyalgia, like irritable bowel, migraines, those are now believed to be due to the brain abnormally receiving normal input. So antidepressants are helpful, the anti-epileptic drugs like the gabapentin, those sorts of medicines. Some of your viewers may know them as Neurontin and Lyrica. Those medicines can help. Anti-inflammatories may help, but really it's a self-management that will help. Opiates have not been found to be effective and may actually harm the patient who has a functional type of pain.
We just have a couple of minutes left,
Sure.
Actually about a minute and a half left. What are the final words you'd like to give to our viewers about pain management, about things to look out for, something that you can summarize very briefly?
I will do my best. I think I would tell your viewers that they are the ones who are struggling with their pain and their doctor wants to help, but their doctor can't do it alone. Managing one's chronic pain is really a journey that the patient walks with their family. So what the patient can do is to learn as much as possible about their diagnosis, find a doctor that understands and will discuss with them the background of their problem, and help them to be empowered to manage their own pain through things that we've demonstrated can be effective.
I think that's going to have to be the last word for this your portion of the show,
Sure.
and I can't tell you how much we appreciate you joining us. I know our viewers have profited a great deal by listening to you, and I will come back. When we come back, I will give you that NIH NCAM web address. You've been watching The Verdict. We've been visiting with Dr. Rachel Franklin. We'll see you in a minute.
Thanks. I need my phone.
There are now 11 million of us who live here and work here. I was 15 when I came here 6 years ago. I raised my family here. drive my truck to my job every day. The only difference between now and 6 years ago, I do it legally. I wanted to. Because this is my home.
All children deserve a life of hope and love, but sometimes they experience a life of pain, neglect, and abuse.
When that happens, each child deserves all the quality assistance and representation that can be offered in our legal system. For more information, call 23-CHILD.
Oklahoma Lawyers for Children, helping to bring hope and love back to the lives of abused children.
You will always be Mom and Dad to me.
I think for us, once we got started and we began to see the tremendous need just within our state, it really was just a calling for us. The blessings far outweigh any obstacles that we've faced.
You will always be Mom and Dad to me.
The Journal-Record is pleased to be a sponsor of The Verdict. The Journal-Record, since 1903, the best source of Oklahoma business news and legal information.
And for almost 30 years, Oklahoma political, government, and business leaders have turned to the McCarville Report for accurate, reliable, inside information. Visit the McCarville Report online.
Welcome back. We enjoyed our visit with Dr. Rachel Franklin from OU Medicine today, talking about chronic pain and opioid overuse and abuse. I do have a couple of websites to give you. I want to give you her website, which is oumedicine.com. And of course, The Verdict has a website, theverdict.tv. And as I indicated in the segment, the NIH website that may help you if you're interested in some of the topics we were talking about today. We don't have a slate for, but I will give it to you verbally. nccih.nih.gov. nccih.nih.gov. We'll put it on the Verdict website. We're out of time. You've been watching The Verdict. Thanks for watching. Mick will be back next week. I'll see you then.